welcome back to our third of 4 webinars for the East African Snakebite Symposium 2025. I very much hope that you've been enjoying the content so far. We have set up a symposium WhatsApp group, which I'm sure a few of you have joined already, to help communicate useful information to participants. And I've added a link to that chat in the top of the chat group now. You will have access to all of the materials through the websites of all the sponsoring organizations. As an interim measure, I have set up a page on our www.taf-eastafricanreptiles.org website. It's there also in the chat. And the first 2 videos have already been posted there, and PDFs of the lectures. This will be updated as all the videos and lectures become available. I understand that Daktari Online have been emailing certificates out directly to participants. If you haven't had your certificate, please email me. I've also put my email in that chat. Email me with your name, the email which you registered with, and I will follow up with Lily about that. For non-medical attendees, I know some of the content has been quite deep. However, I hope that with access to the lecture content and the videos, you'll be able to go back through and make some more sense of it. We're available to answer questions either by email or through WhatsApp. So don't be shy. This is a learning experience for everybody, and we really want to hear from you. So 2 years ago in 2023, we were extremely lucky to have our next speaker attend the conference in Watamu in person, where he received a Lifetime Achievement Award for his work in snakebite through the years. Tonight, he's back to talk about the clinical management of snakebite. Professor Sir David Worrell is an Emeritus Professor of Tropical Medicine, University of Oxford. He was formerly head of the Nuffield Department of Clinical Medicine in Oxford and founder in 1979 of the Oxford Tropical Medicine Research Network, starting the Kemry Oxford Wellcome Unit in Kilifi in 1989. He was also a co-director of the Global Snakebite Initiative. In Africa, he has lived and worked in Ethiopia and in Nigeria, where he developed his interest in snakebite, and visited Kenya many times since 1968. Tanzania, Uganda, South Africa, Zimbabwe, Niger, Burkina Faso, Sierra Leone, the Gambia, and Cameroon, to mention a few. He first met James and Sandra Ash in the late 1970s when James was working in the zoology department in Oxford, and after 1990 at the original Watamu Snake Farm known as Biochem. His publications cover infectious, tropical, and respiratory diseases, venomous animals, envenoming, plant and chemical poisoning, and expedition medicine. His career has been as a physician, a zoologist, teacher, researcher, resident, and traveler in Africa, Asia, Latin America, and Papua New Guinea. Professor Worrell will be joined tonight by Dr. Eugene Irulu, one of Kenya's leading medical snakebite experts. Dr. Eugene Valentine Irulu is currently a doctor in charge at Watamu Hospital in Watamu, Kenya, where he has passionately treated snakebite patients for the better part of 3 decades. He is a graduate of the Volgograd State University of Medicine in Russia. Dr. Irulu has been a frequent presenter, including at the Global Snakebite Initiative and IST congresses in Melbourne, Oxford, Dakar, and Abidjan. He has participated in the writing of national snakebite management guidelines for Kenya and in the production of educational videos on snakebite management in Benin. Dr. Irulu has also served as a consultant on snakebite management for various local hospitals. He has acted as a peer review for PLOs on snakebite-related manuscripts.
Well, thank you again, Ali, for that generous introduction. Dr. Irulu and I are really looking forward to discussing the clinical management of snakebite with you all this evening, because it's a subject that's very close to our hearts. And we've both sought to gain experience over many years of this very difficult subject. I've summarized on my title slide what I hope to cover this evening, everything from a bit of revision on first aid, which Kyle covered in the first of these CME sessions, through the patterns of envenoming, and the various stages of medical management of snakebite patients, right through to the care of the bitten limb, and everything in between. So the first thing to deal with is first aid. And I want to emphasize that first aid is something that happens as soon as possible after the bite. It's not something you wait until you've got to medical care, to hospital or to the clinic. It's something that should be started immediately by either the bite victim, herself or himself, or by any other person who happens to be around. So it's good for community education if everyone in the community knows something about the principles of first aid of snakebite. The aim here is to slow down the spread of venom from the bite site, to allow more time for the patient to be transported to medical care. And the second aspect of first aid after the initial procedures, which I'll be describing, are to move them to the nearest clinic or hospital as quickly, safely, and as passively as possible, because you want to avoid exercising the bitten part, which will help to spread venom away from the bite site and into the body as a whole. So the do's of first aid are, first of all, remove the victim from danger, that is danger of further bites, and reassure them. And I hope that this talk will give you plenty of grounds for reassuring a snakebite victim that they're not going to die rapidly and horribly in the next few minutes or so. Secondly, sit them down or lay them down flat and try and get them to relax their whole body, especially the bitten limb, again to avoid propelling the venom away from the bite site. Remove any tight objects on the bitten limb, and I'm going to be explaining later about the pressure pad splint immobilization method, which I believe is the most practicable and the method which has the most evidence supporting it at the moment. And then transport the victim to hospital or clinic. The don'ts are to chase or try to kill the snake, pursue the snake into the undergrowth and so on. This risks further bites, and we're not in favor of killing snakes anyway. Don't waste time with academic exercises about academic discussions about what sort of snake it could have been, or whether it was a venomous one or a non-venomous one. The principle of first aid is to do something immediately and not to waste time with speculation. Don't interfere with the bite wound. Don't rub it, squeeze it, suck it, cut it, shock it with electricity, freeze it, apply plants, apply the black snake stone or anything else. You'll be amazed how many first aid techniques have become fashionable in different parts of the world. Don't apply any sort of tight ligature, tourniquet or band around the bitten limb. I'll be showing you graphically the dangers of such methods, even though they are amongst the most popular methods used throughout the world. And don't give alcohol or any drugs except paracetamol is a safe analgesic given in the full adult dose. And don't delay travel to clinic or hospital for any reason, certainly don't delay to see any local practitioners. Now, this is the pressure pad immobilization method. Imagine here is the venom depot deposited in the tissues as a result of the snake's strike and injecting venom into the tissues. And you'll see that surrounding the venom are green lymphatics and blue veins, and they will be transporting away the various toxin molecules in the venom at different molecular sizes. And the aim of compression here with the pressure pad is to compress veins and lymphatics in the immediate vicinity of the venom depot. So in the hope that compressing these vessels will reduce their ability to transport venom away from the bite site and spread it around the body where it has life-threatening potential. All you need in the way of apparatus is a roughly fist-sized pad of any available material. It could be clothing, it could be cloth, handkerchiefs, bandages. This is a very smart one, but it needn't be as smart as that. And this pad should be applied directly over the fang marks over the bite site. The next stage is to bind it on tightly with a non-stretchy band or bandage. And finally, most important, a long splint to immobilize the whole limb and to stop it moving and stop the muscles squeezing on blood vessels and lymphatics. Now, transporting the victim of snakebite to hospital or clinic, this should be done as rapidly but as safely and, as I've said before, as passively as possible. And patients should be transported, if possible, in the left lateral semi-prone position. This is the recovery position. And this is not just arbitrary. It's on the left side with the head downwards for a particular reason. It's to minimize the risk that the patient might inhale their vomit or secretions. And early vomiting is a common symptom when the patient is systemically envenomed. So this is the anatomically optimal position for reducing the risk of inhaling vomitus and other secretions. And on the way to medical care, prevent shock, airway obstruction, and respiratory failure as far as this can be achieved with the available equipment. Also discourage traditional treatment or any wasting of time to visit traditional practitioners. Here are two clever ideas in different parts of the world. Here in a remote part of the north coast of Papua New Guinea, a friend of mine is being carried in a handmade stretcher by some friendly local people. He was carried for several hours to the nearest hospital. So immobilized, that's excellent. And here in Nepal, my colleague, Dr. Sharma, has popularized motorcycle transport in areas of the country where there are no roads for vehicles, but there are motorcycle tracks. And this involves recruiting village-based motorcyclists who are willing to do this. Now, a quick revision of what you've heard already about the main types of envenoming in East Africa, particularly the sorts of snakes responsible. So first of all, local tissue damage caused by the venom. This is really caused by three different groups of snakes: adders such as this puff adder, spitting cobras such as this ashes spitting cobra, and burrowing asps or night adders. They can also cause local necrosis, local gangrene or death of tissue at the site of the bite. Then low or falling blood pressure is particularly of a feature of envenoming by the large vipers like the puff adder, the gaboon viper, and the rhinoceros horn viper, but also carpet vipers. So bleeding or non-clotting blood is particularly a feature of envenoming by the carpet vipers. There are several species in Africa. The boomslang and the twig or vine snake, both of these are tree snakes. Finally, paralysis, spreading paralysis, descending paralysis. The most dreaded paralytic snake in East Africa is, of course, the black mamba, but also two of the neurotoxic cobras, the Egyptian cobra and the forest cobra. And if you go a little further south, by the way, into southern Africa, there's at least one species of viper there, the Burg adder, which can cause paralysis as well. So this is the course of events when the patient reaches a hospital or clinic. They may require urgent resuscitation to save life. That must not be forgotten. Just because it's a snakebite patient, it doesn't mean they should not be afforded all the sort of CPR that any other desperately ill patient would be given. Then there's a process of assessment, including the clinical history, the chronological history, the physical examination, a few simple investigations, and then the formulation of a treatment plan, which may or not include antivenom, and observation while the patient remains under medical care. Then finally, as the patient recovers, rehabilitation, restoration of normal function of the bitten limb is extremely important in a problem that largely affects working people in rural environments. They need to get back to work as soon as possible. And discharge from hospital with, one hopes, advice about how they might prevent further bites and whatever follow-up may be needed. So resuscitation, a patient comes in unconscious. You should go through the normal process of checking the airway, breathing, circulation, disability, and you've already removed them from exposure. And check their level of consciousness. Are they rousable? Is there visible breathing? Do they have a detectable, a palpable pulse? Do they have a detectable blood pressure? If not, one should go ahead, straight ahead, with full cardiopulmonary resuscitation until life is restored. Now, the history, a few key questions. You can get a lot of information very quickly by asking these questions. First of all, ask the victim or the person who's accompanied them to hospital, where, in which part of your body were you bitten? Point, please. And you will then be directed to the first bit of clinical evidence about whether the patient may have been envenomed or not. And as I shall tell you in a moment, a snake bite doesn't necessarily result in injection of venom. So puncture marks, swelling, inflammation, bruising, persistent bleeding, and evidence of the damaging effects of pre-hospital traditional treatments will all be evident at the site of the bite, and you need to know about that. And then next, when did it happen? How long ago? Because the problem is, if the patient was bitten just outside the hospital or very recently, there may not have been time for signs of envenoming to develop. In fact, there's one famous case where signs of life-threatening envenoming did not develop for 48 hours after the bite. That's most unusual. Usually it would be within a couple of hours for vipers and so on. Another bit of useful information in this detective story, you're trying to get as much information as you can about which snake was likely to be the cause and therefore which sort of envenoming the patient may be in for. What were you doing when you were bitten? The circumstances, if they were bitten while they're asleep in Africa, it's going to be a burrowing asp or a spitting cobra, most likely. If they were bitten in the trees or in a plantation, one of the tree snakes, like the boomslang or the twig snake. Where is the snake that bit you, and what did it look like? Now, I've already warned you, you mustn't kill the snake or go chasing for it. But things being what they are, human nature, it's a very common response to kill the snake. So it's highly likely that there will be a dead snake. So what did it look like? Is there a photo of it? Nowadays, everyone carries an iPhone, and just a few photographs can be extremely helpful, or there may be a dead snake. And if it was killed but left behind, I used to send someone to fetch it on whichever condition. On one occasion, the snake had been burnt, but I was still able to make a useful identification even with the burnt corpse. And very important too, how have you, the patient, been feeling since the bite, and how do you feel now? And you can check whether any symptoms of envenoming have developed: local envenoming, local pain, swelling, and so on, spreading swelling, or faintness, collapse, perhaps bleeding, and so on. Now, the physical examination, and the key thing here, you're looking for signs of local and systemic envenoming. So this is a very important slide, actually, bites without envenoming, because many, if not the majority, of patients who arrive claiming that they have been bitten by a snake will be in this category. The so-called bite may have been a non-bite, treading on a thorn or a splinter in the dark. It may be a bite by a non-snake, such as a legless lizard, or a fish or a rat, something like that. Or it may have been a bite by a non-venomous snake. These are very frequent. Or finally, it may have been a bite by a venomous snake, that did not inject venom, the so-called dry bite. And you may think, well, that's pretty odd. Why should a venomous snake bite you and not inject venom? Well, it happens on average of about 50% of occasions, more with some species than others. But it is possible for a venomous snake to bite you and not inject venom. It can be quite common. And that is one of the reasons why you can be reassuring to a snakebite victim, even if they've been bitten by a venomous snake. So how should you manage, how should you treat these patients who have no envenoming? Well, you shouldn't just send them away. I've already given you this cautionary tale about the late development of envenoming. I think you should try to observe the victim in hospital for at least 24 hours, unless a non-venomous snake has been brought and can be confidently identified as a python or something like that, or a brown house snake, confidently identified as a non-venomous snake. Then and only then can you send them home after giving them a booster dose of tetanus toxoid, because any penetrating injury, even a thorn or a non-venomous bite in the wild, may expose the patient to the risk of tetanus. So, and also a booster dose of tetanus toxoid is reassuring that the doctor's doing something. And reassurance is also very important. Now, a warning, as Ali's already said, I shall be showing photos of snakebite patients, of mainly my patients in different parts of Africa and the world. And I'm afraid that non-medical people may find these very distressing. I assure you, I'm not showing you my worst ones, my most horrific ones. But since I am primarily aiming to speak to a medical audience today, it's very important that I should show you what snakebite can do and how you perform the procedures necessary to manage snakebite patients. I want to reassure you that permission for taking and using these photos for teaching was given by all the patients, all their relatives and guardians. So you have been warned. So here to start with is a quick summary of some of the main clinical effects of envenoming in East Africa. First of all, local tissue damage. This is a victim of a carpet viper, showing swelling and blistering, a demarcated area of dead tissue, and finally the separation of skin and subcutaneous tissue. This is the necrotic, the irreversible necrotic effect of snake venoms, of some snake venoms. Then there's the low or falling blood pressure. This victim of a puff adder is hypotensive. I'll be coming back to him in a minute. Then there's bleeding, spontaneous bleeding from the gums, under the tongue. It can be from other sites, with or without the demonstration that the blood will not clot. And I'll be describing this simple bedside test, the 20-minute whole blood clotting test, which I know many of you use already. Finally, paralysis. And here are two patients, a forest cobra patient from Liberia and a black mamba patient from KwaZulu-Natal in South Africa, showing the early signs of descending paralysis, typical of the paralytic effects of venomous snakes. The drooping upper eyelids and the paralysis of the facial muscles, and eventually the inability to open the mouth or stick out the tongue, and much more dangerous, a bit later on, the inability to protect their airway and ultimately to breathe. So we'll come back to that in a moment. So first of all, low or falling blood pressure with the risk of shock. So the signs of this form of envenoming are a blood pressure that is low or falling or even unrecordable. The blood pressure that falls by more than 20 millimeters of mercury when the patient sits up or is propped up. This indicates a low circulating blood volume. Probably a lot of the blood volume has leaked into a massively swollen limb. Think of those patients with puff adder bites you've probably seen. A rapid or rising pulse rate of low volume, a sort of thready pulse. And ultimately a patient who is collapsed, confused or even unconscious. The skin is cold, pale, sweaty, and bluish in color, cyanosed. the tongue is cyanosed, and the patient may be passing little or no urine. All these add up to shock or damage to vital organs and tissues secondary to a low blood pressure. So what is the treatment? Well, the urgent treatment, which is often forgotten actually, is to lay the patient flat with their head down and their feet raised. This can often raise the blood pressure very rapidly. Encourage them to drink sips of water if they're conscious, or if not, consider intravenous fluid replacement. Or if that fails, you may even have to consider drugs to raise the blood pressure. So here's an example of the change in blood pressure of a patient from lying to sitting up. This patient was bitten by a puff adder, very familiar venomous snake to all of you, I'm sure, in East Africa. Lying flat, his blood pressure was 135/70. Well, not bad, that's okay. No reason for concern. But when he was propped up or sat up, it dropped dramatically. And this is a very good example where a lot of the circulating blood volume had leaked into this massively swollen limb. See the big blister there as well. Now, the second group of very important signs are bleeding and non-clotting blood. So the signs here are persistent local bleeding at the bite site and also from healed wounds. Here's an example. This is 40 minutes after the bite, but blood is still pouring from these two fang marks. This is a sure sign that the blood is incoagulable. The venom has broken down the mechanism for controlling bleeding. And spontaneous bleeding, particularly the gums. This is a carpet viper victim, but also it could be from the nose, the gum nose, urine, check the urine with a dipstick, or from the gastrointestinal tract. I know that laboratory facilities may be limited in the areas where snakebite is most common, and you may not have the benefit of blood clotting tests and platelet counts. But never fear, there's a simple blood bedside test, the 20 minutes whole blood clotting test, or 20 WBCT. The only bit of equipment you need for this, and this is most important, a new, clean, dry, preferably soda glass vessel. If it's not new, clean, dry, and glass, it may not activate clotting in your blood sample from the patient, and you'll get a false positive result. So that's why I've been so particular about these different adjectives to describe the sort of tube you need. In a study that David Williams and his colleagues did in Papua New Guinea, he found that this test was more than 90% sensitive and specific for detecting defective blood clotting with a fibrinogen concentration less than 0.5 grams per litre. So here is the test. Here is a normal positive result. In this case, the glass has activated clotting, and there's enough clotting factors in this sample to cause a solid clot. However, in this case, the blood is just like water after 20 minutes. And you'll see in the corner of your eye here that the patient is also bleeding profusely from razor cuts he has ill-advisedly made at the site of the bite. So this is the positive result, non-clotting blood, indicating what is technically called consumption coagulopathy. All the clotting factors have been used up as a result of the action of venom toxins. So the treatment here, antivenom, can be most effective within a space of a few hours. It may stop bleeding within 20 minutes and may restore blood coagulability, judged by the 20 WBCT, in just a few hours. You should rest the patient in bed to avoid trauma, injuries which may promote bleeding, and avoid procedures such as surgery and drugs, or I say avoid or postpone procedures like surgery and drugs that cause bleeding. So aspirin and non-steroidal anti-inflammatory drugs, sorry, I've made a mistake there, should not be given because they inhibit platelets. do not give blood products such as fresh frozen plasma. And that may seem contradictory. If the patient's lacking clotting factors and bleeding as a result, why not give them ready-made ones from transfused blood or fresh frozen plasma? The answer is this: until you have neutralized the venom with an antivenom, that clotting factor that you give intravenously will be broken down by the venom toxins and will be turned into clot, which may well cause serious damage to the patient. So try to avoid giving blood products in a patient who has incoagulable blood. The important thing is to give antivenom. So paralysis is the next very important life-threatening form of systemic envenoming. The early warning here is this technical word, sorry about this, ptosis. It means that the patient cannot raise their upper eyelids when asked to look up. They may also have double vision because their eye muscles are paralyzed and very often a bit later can't open their mouth or stick out their tongue or speak or swallow. Later on, dangerously, they may not be able to protect their airway, so they start to gurgle and they're not able to keep their airway free of secretions or vomit. And when the respiratory, the breathing muscles begin to be involved, the breathing will become labored. You may notice that the patient sticks out their abdomen when they try to breathe in, so-called paradoxical breathing. As a result of the poor ventilation in the lungs, the lips, tongue, and conjunctivae may become blue, or cyanosed is the technical term. And there's a special form of neurotoxicity, which I won't go into here, which is a sort of fine shimmering contraction of muscles called fasciculation, which is a feature of mamba bite. Now, the treatment here of paralytic envenoming is first and foremost antivenom, and this may be quite rapidly effective, particularly with cobra bites. You need to observe the patient carefully, even if they have these very early signs of paralysis. Watch for the progression of ptosis, watch their breathing, use a finger oximeter to detect if they're not oxygenating properly with the lungs. Nurse these people in the recovery position, I've already shown you what that is, and check for gurgling secretions in the upper airway, which is a danger sign that the patient has this paralysis of these muscles. Avoid drugs that may put the patient to sleep, which might be a heavy analgesia like an opioid, or it might be a sedative drug or a benzodiazepine. Avoid these in patients with paralytic snakebite. Give oxygen by any means possible, by mask or nasal catheters, and maintain an airway. This may be done often by positioning the tongue, the jaw, a Goodell airway, oral airway, or with sandbags. By positioning a patient, you can often maintain an open airway long after they will be obstructing. And eventually you may require endotracheal intubation and assisted ventilation, as is going on here. And an alternative here is to consider hospital transfer if it's safe and if it's feasible. So I said that the earliest sign of this very dangerous development of paralytic envenoming, which you get with mambas and neurotoxic cobras, is this ptosis, or paralysis of the upper eyelids. But don't just assume that they've got this ptosis because their eyes are closed or drooping. They may just be tired, exhausted, dropping off to sleep from sheer exhaustion of getting to hospital and so on. Do a formal test. So here the patient is being asked to look upwards, and you can see she's contracting her forehead muscle here, and she's just managing to keep her eyelids above the pupils. So far she hasn't got ptosis, but a little bit later she was beginning to get paralyzed, and you can see now she's hooding or partly covering the pupils. Just to demonstrate, when she'd fully recovered, the contrast is quite dramatic. So this is how you should test formally for ptosis. don't assume ptosis. It's such an important sign. Test it formally by asking the patient to look upwards. Now, a brief mention of spitting cobra injuries, which Kyle mentioned in his in the lecture in the first week. Spitting cobra injuries cause intense, insufferable pain, inflammation of the conjunctiva, white discharge, spasm and swelling of the eyelids. And the danger here is that the cornea, that's the outer protective layer over the lens of the eye and the pupil of the eye, may be ulcerated by the local necrotic effects of the spitting cobra venom, and then becomes vulnerable. It becomes open to secondary infection, both by viruses and bacteria. And this can lead to blindness. So here's an example from one of my patients who'd had a spitting cobra injury many years before, had developed a corneal opacity, and is blinded as a result of this spitting cobra injury. So what you should do is first aid is most important. Wash out the affected eye or eyes with as large a volume of water or other bland fluid as is available. Wash out the venom. And the only thing that really works for pain, and I have this on the authority of a sort of human guinea pig of mine, my late friend, Dr. Visser from South Africa, that the only thing that works for the pain of spitting cobra spits is local anesthetic. But the trouble with recommending this, and I thought seriously about whether I should mention this or not, is that this is a potentially dangerous treatment. You should only ever give one drop once, because once you've anesthetized the eye, you make it very vulnerable or sensitive to injury. But it is a most marvelous way of relieving the intense pain of spitting cobra injury. You should also apply antibiotic drops, for example, chloramphenicol, or exclude a corneal abrasion. If you've got an expert eye doctor rather, man or woman, with a slit lamp, or you can do fluorescein staining to detect a corneal abrasion. Otherwise, you should apply prophylactic chloramphenicol eye drops. Now, I just wanted to show you a horror slide now. This is a horror slide, the devastating effects of traditional treatments. And worldwide, the most commonly used first aid treatment for snakebite is a tight band, varying its degrees of tightness from being so tight that it stops the arterial supply to the limb, which will inevitably result in gangrene. So here are two horrible results: a gangrenous foot, a gangrenous child's arm from the use of a really tight band left on for hours. So this is why responsible doctors will never recommend a tight band ligature or tourniquet around the bitten limb. It's just far too dangerous. Another common treatment is to apply herbs to the wound or to swallow them, which causes vomiting, which can be very misleading. Making incisions with the hope that it will somehow let the venom leak out. But if the patient's blood is incoagulable, as in this patient's case, a carpet viper patient, they will bleed to death from these cuts. And finally, you've heard from Kyle about the snake stone, which is made of various materials, pumice or burnt bone or charcoal. It's applied to the wound, but they have to make a cut first of all to make it stick. And these are ineffective and potentially dangerous. So all these methods, traditional methods, are ineffective and potentially dangerous. So on to the most specific form of treatment now, antivenom treatment. And you will remember antivenom is raised in large animals like horses and sheep by injecting initially tiny, increasing doses of venom so that the animal's immune system produces neutralizing antibodies against the venoms that you're using to immunize the animal with. And the resulting hyperimmune serum or plasma, rich in these antibodies, is refined in various ways, and that's what will end up in the vial of antivenom, either freeze-dried or lyophilized or liquid. So when to give antivenom? Antivenom, as we heard last week, is expensive, scarce, not very well distributed, quite controversial in quality amongst many manufacturers. So it's not something you just throw around. You certainly don't give antivenom to every patient who thinks they've had a snake bite. You may not even give it to patients with very mild local envenoming. But what are the indications or the reasons for giving antivenom? Well, first of all, certainly a patient like this little boy bitten by a carpet viper who's got a low or falling blood pressure. He's in shock. He needs antivenom urgently. Also, bleeding, spontaneous bleeding, or incoagulable blood. These patients are in danger of having a massive fatal bleed into the brain or elsewhere, so they need antivenom immediately. Paralysis. Patients here with bilateral ptosis. This man recovering, so he's able now to contract his forehead muscles, but he's still not able to open his eyelids. In a day or two, he will be able to. In the meantime, he's being mechanically ventilated. Paralysis is certainly an indication. And then finally, local envenoming, but not every mild, trivial case of a bit of local swelling and pain. That is not necessary. But if the swelling is rapidly progressive, for example, in this patient, the bite was on the hand and the swelling is moving very rapidly up the limb, and particularly for bites on the fingers and toes, because these are very vulnerable to develop necrosis and require amputation, and we need our fingers and toes for everyday activities. So how to give antivenom? First of all, as we heard last week with that excellent session with David Williams and Dr. Kadil Kar, you should pre-treat with adrenaline. The adult dose is 0.25 mL of the 0.1 solution. And for children, it's a graded dose, 0.1 mL per kilogram. And this is given subcutaneously before you start giving the antivenom, 5 to 10 minutes before you start the infusion of antivenom. Don't waste time with so-called hypersensitivity tests, skin tests or conjunctival tests. They're unreliable. Check the specificity of the antivenom you're going to give. Are you sure it covers the venom of the species of snake which you think or know was responsible for your patient's envenoming? Now, the initial dose is tricky, and this will vary with the type of antivenom, with the species of snake, and with the clinical severity of envenoming. But the important thing to say is that the same dose is given for adults, pregnant women, and children. So pediatricians be aware here, the dose of antivenom is the same for children as for adults. Antivenom is given intravenously, either by slow injection, about 2 mL a minute, timed with a watch, or diluted in intravenous fluid. And this could be a normal saline, given over 30 to 60 minutes. In adults, you can safely use 200 to 5 mL over 30 to 60 minutes. But with children, you don't want to overload them with fluid, so be cautious. A maximum of 25 mL per kilogram body weight per hour. So for a 4 kilogram infant, a maximum of 100 mL over 60 minutes. For a 16 kilogram child, 400 mL maximum over 60 minutes. Antivenom reactions. As you'll all be aware, anyone who's used antivenom will have seen an antivenom reaction, and they're very frightening. But you should be confident that you can treat them, provided you spot them. And that's why supervised administration of antivenom is so important. Early reactions are either anaphylactic, these happen within 1 to 40 minutes of starting, and the treatment is absolutely uncontroversial. It's intramuscular adrenaline, 0.1%. The adult dose is 0.5 mLs. For children, 0.01 mLs per kilogram. It's given intramuscularly into a muscle that will absorb the adrenaline quickly, ideally the side of the thigh, the vastus lateralis muscle on the side of the thigh. And then you can give an antihistamine to deal with the symptom of itching. So this little girl has the mildest form of anaphylactic reaction. She's got generalized urticaria, and we would have given her adrenaline into the thigh, the lateral thigh just here. This man has much more serious life-threatening anaphylaxis. He's got swelling of the lips, tongue, gums, and upper airway, so-called angioedema. And he certainly needs urgent adrenaline. Pyrogenic reactions are fevers caused by impurities in the antivenom. It's a fault of antivenom production. So within an hour or two of giving antivenom, the patient will start to shiver and shake and have feverish rigors and may collapse as well. You should cool them physically, that is tepid sponging and fanning. Give them paracetamol, an antipyretic drug that is, and you may need to give them fluid resuscitation as well. So they're the early reactions that will happen while you should be around near the bedside supervising the administration of the antivenom dosage. Late reactions, though, will be 5 to 15 days later, sometimes after the patient has left hospital, and they can be very unpleasant. Swelling of the joints, fever, lymph node enlargement, urticaria, and other things like that, and terrible muscle pains and stiffness. The treatment here is you could start with a course of oral antihistamine, such as chlorphenamine, that's Piriton, one of the makes, or they may need a course of steroids, of prednisolone. And I should say that this is about the only use for steroids in snakebite. I know that many doctors use steroids as a routine for every snakebite case, which is probably damaging and certainly not necessary. But occasionally you may have to use steroids to treat these very uncomfortable late serum sickness reactions. Now, what about the dose of antivenom, and when should you give more? Well, for low or falling blood pressure and paralysis, the patient may stabilize or show some improvement as soon as 30 to 60 minutes after the dose. If not, you can repeat the dose after that interval. Bleeding may stop within 30 minutes, and non-clotting blood, that is a positive 20-minute WBCT, may become clotting within 6 to 12 hours. If not, you should repeat the dose. With local swelling, the initial dose is very important because the longer you leave it after the bite, the less likely antivenom is going to affect the course of the local tissue damage. But you may notice that the spreading is slowing down or stopping within a few hours. But whether you give a second dose or not is very controversial. Now, Dr. Iruli reminded me of how important it is to address the problem of pregnant women, although it's relatively rare, fortunately, the problem of snakebite in pregnant women. The dangers here are that during both trimesters of pregnancy, pregnant women have an increased risk of premature labor, fetal death, other complications of pregnancy, and maternal mortality. One thing you should do during pregnancy is to avoid the supine hypotensive syndrome. That's the problem with if a pregnant woman is asked to lie on her back for long periods, the uterus may press down on the inferior vena cava and reduce the venous return. So that's obviously not the thing to do. So make sure the poor woman is put on her side, not forced to lie on her back as a result of your medical attention. Be alert for vaginal bleeding and signs of fetal distress. However, you can monitor fetal distress, perhaps with a fetal monitor, or looking for fetal heart rate and so on. Anti and postpartum bleeding and abruptio placentae are the main dangers. And these are particularly problems of hemorrhagic snake bites where you have bleeding and incoagulable blood. But snake bites that cause shock can also damage the mother and the fetus. So treatment here, and this is very important, that's why I put it in bold. Benefits of antivenom and adrenaline, both for prophylaxis or treatment of antivenom-induced anaphylaxis, far outweigh any theoretical dangers. So you should not hesitate to give pregnant women antivenom if they need it, if they fulfill the criteria, nor should you hesitate to give adrenaline in either of these situations. And if the delivery of the baby or a need for urgent obstetric surgery is urgent, after giving antivenom, you can speed up correction of coagulopathy by giving blood products. That seemed to go against what I said earlier, but in this particular situation, once you've given antivenom, you can speed up restoration of blood coagulability there's an imminent delivery or surgery or urgent surgery by giving blood products. But be cautious using any drugs in pregnancy. That's a common caution. Now, care of the bitten limb. I think you should nurse the bitten limb in the most comfortable position. Be guided by the patient. Avoid excessive elevation of limbs, because this can actually reduce blood perfusion to the bitten limb and prejudice the recovery, or even increase the risk of tissue necrosis. So be guided by the patient. Most comfortable position. Regular full dose paracetamol is the best thing for pain. If you have large tense blisters like this, I believe in aspirating them with a fine needle. I do not like de-roofing blisters, because I think that exposes large areas of dermis, and very often the environment of a hospital where snakebite is common can have a lot of flies and other things and dust and so on. I'd far rather leave this protective layer after removing the risk of their rupturing by fine needle aspiration of the liquid contents. Encourage early rehabilitation, which means don't encourage the patient just to lie in bed recovering. Encourage them to start using their bitten limb. Rather tough, I agree, but it will speed up their eventual recovery and their return to work, which is the important thing. Now, infection. This is very important. I think every patient with proven or suspected snakebite deserves a booster dose of tetanus toxoid. It's also a good placebo. It shows that the doctor is doing something, even if that's all the treatment they're going to get before they're discharged. But look out for signs of secondary bacterial infection. This may be difficult because venom itself can cause inflammation and swelling and heat. Some of the characteristics of infection can be produced by venom alone without a secondary infection. However, in a case like this, this is a wound abscess close by a snake bite. And this is hot and red and swollen and fluctuant. It's obviously a wound abscess. So either drain this with a needle or otherwise drain the pus out of an abscess. Do not give routine prophylactic antibiotics. Now, I know this will cause dissent amongst the audience because, like steroids, it's a very common standard treatment for every snakebite patient is to give them antibiotics. But all the evidence now suggests that this is not only not necessary, it's potentially harmful, and the chances are that the antibiotic you give will not be effective against the peculiar range of bacteria that contaminate snakebite wounds. A lot of them arise from the snake's mouth itself. They're very odd bacteria. They're not your standard hospital nosocomial bacteria. So antibiotics are not indicated unless the wound has been interfered with, incised or mucked around with, or if the wound is already showing signs of gangrene, necrosis. Clearly, there's a risk here of particularly of anaerobic infections, and I've seen fatal tetanus after necrotic snakebite or wound abscess. In these situations, you should give antibiotics straight away. Which antibiotic to use? There's been a lot of review of this recently in the literature, and for blind or empirical treatment, ciprofloxacin, a third-generation cephalosporin, such as cefotaxime, ceftazidime, or ceftriaxone, or, if you can afford it or get it, piperacillin, tazobactam, are appropriate. They're appropriate for the range of bacteria most likely to be the cause of your patient's secondary infection. But the very popular combination of amoxicillin clavulanate has proved to be very ineffective in snakebite patients. And that may be a bit of a shock to some of you who use it. It's a very convenient drug, but it is not recommended in the reviews looking at this particular problem. Finally, surgical treatment. Tim Hardcastle is going to deal with this next week, so I'm not going to preempt him, but necrotic tissue will be debrided early on to reduce the risk of secondary infection, as well as aiding recovery, speeding recovery. So this shows how a necrotic foot, the superficial skin and subcutaneous tissue is removed, is debrided, and split skin grafts are applied. Discourage fasciotomy. Now, this is a big subject. I will leave this to Tim Hardcastle. I am very much against fasciotomy for very many reasons, which I won't go into now, but it's become such a popular, fashionable treatment in some parts of the world, and it's often undertaken without any confirmation that there is raised intracompartmental pressure, which is the cause of the cause of the compartment syndrome. So I'm very much against fasciotomy, but I'll leave Tim Hardcastle to deal with that next week. So now, in summary, ladies and gentlemen, thank you for your attention. I've been speaking for an awful long time. I don't know whether Ali has been giving me the sort of thumbs down, but I'll try and conclude now. But just as a summary, these are the essentials, I believe, for managing snakebite patients. First of all, treat every snakebite patient as potentially a medical emergency until and if you can get some basic information from the history, from the physical examination, and from simple bedside tests, such as the 20 WBCT. This is reassuring. In many cases, no venom will have been injected and no specific treatment will be needed. But all cases of suspected snakebite deserve reassurance, because it's a very frightening experience. I've had 2 snakebites myself. It's extremely frightening. The more you know about it, the more frightening it is. And a booster of tetanus toxoid is indicated. Ideally, you should keep patients under observation for 24 hours, unless the snake or a specimen, either a specimen or photo, can be confidently identified by an expert as being non-venomous. Shock or respiratory obstruction and paralysis will require urgent treatment. Specific antivenom, assuming you have access to it, should be given as soon as this is indicated, but very selectively, not to everyone, to the patients who really need it. It should be given in the same dose to all patients, including pregnant women and children. It should always be given by intravenous injection or infusion, and it should be given after prophylactic subcutaneous adrenaline. And antivenom should be administered under close supervision. Beware of early antivenom reactions. Beware of complicating infections, but do not use prophylactic antibiotics in all cases. Start to exercise the bitten limb as soon as possible to speed up the restoration of the vital restoration of function. And one final point, ladies and gentlemen, don't discharge the patient from hospital without giving them some advice, and preferably their family and neighbors as well, about how they might prevent further bites. Give them advice about how they can avoid this accident happening again. So thank you very much for your attention, and over now to my dear friend and colleague, Dr. Irulu.
Thank you, David. So anyway, first of all, greetings to everybody. And thank you very much, Ali, for the kind introduction and the invitation to present at this forum. Daktari Online, also thank you very much for organizing this symposium. And I'm very well privileged to present alongside Sir David Worrell, professor, my mentor, and my very good friend. I will shortly present three case reports tying up with what David has presented on the three main syndromes of envenomation. And these are cases that I have been directly involved in managing. So I'll share the three case reports that I've mentioned on syndromic management of snake bites. The first case was a call that I got on the 6th of November 2022 at around 4 o'clock. And this call came from a place called Gilgil. This was a young lady, 26 years old, a young mother who was going around her domestic duties and was collecting firewood and got bitten on the dorsum of her fingers. You can see of her hand, as you can see, there are two distinct bite marks there. That was the initial photo of the bite. She had a bit of pain at the bite site, and she positively identified the offending snake from the color and description of the markings. So it turned out to be Pafada Bitis arietans. And as you can see, it's quite widespread within Kenya. And so we get a lot of bites from this particular snake. For those participants who might not know where Gilgil is, this is about 700 kilometers from where I am in Watamu, and it's in the central part of this country. So unfortunately, there was no antivenom available at the referral hospital she went to, which is the Gilgil Sub-County Referral Hospital. And then she had to be referred to the county referral hospital, which is about 45 kilometers away. But again, she had to go by public transport because of their financial constraints. Then again, not being sure of the availability of antivenom in Nakuru, we were still in constant communication with them. I spoke to Dr. George Omondi of the Kenya Institute of Primary Research, who kindly organized to ferry antivenom, which they had in stock at the institute in Nairobi, to Nakuru. 2 hours later, post-envenomation, the swelling had actually gone just past. They sent photographs and the swelling while on transit, and the swelling had gone past the wrist and the elbow. She was in a lot of pain. As you can see, the bite marks again are quite evident from the photo. So at about 9:30 in the night, they arrived at the county referral hospital. That was about 5.5 hours after the bite. At that time, the swelling was actually approaching the shoulder. A 20-minute whole blood clotting test was done, and the blood clotted. Antivenom was delivered, but unfortunately was not given at that time. I'm not defending the doctor on call that night, but as much as in normal circumstances, he should have given the antivenom as priority, he had a myriad of other emergencies, like it happens in referral hospitals, rather which was rather unfortunate for this victim. But they gave her IV paracetamol and tetanus toxoid. And again, a repeat 20-minute whole blood clotting test was done, and the blood clotted. The following morning, which was about 16 hours after envenomation, the swelling had progressed further to the anterior chest wall, as you can see from this diagram. And she was still in quite a lot of pain. That is when a decision was made to give antivenom, and the antivenom had already arrived. So the doctor made a plan of how the antivenom was going to be administered. We had a conversation with him before he did that. So the first dose of Panaf Premium was finally administered at about 7:30 in the morning after giving adrenaline pre-medication, which was about 15.5 hours post-envenomation, which is quite a long time in snakebite. That infusion ended at about 8 in the morning. A second dose was set up, which again ran without any adverse reactions. But on the third dose, the patient developed itching and urticaria. So they had to temporarily stop the antivenom. And as Professor David Worrell pointed out, you can see there is urticaria which had developed on the patient. So again, this had to be temporarily stopped. And again, the doctor consulted with me, and like Professor Worrell said, this is actually a nightmare stage. And very many clinicians withdraw at this stage. They don't give they stop giving antivenom, thinking that the reactions are going to be worse. But I would still like to reiterate that this is not a contraindication to giving antivenom. From the doctor's notes, which you can see, adrenaline was given with Piriton, countering the adverse effects. But the vitals were fairly stable. You can see the blood pressure is at 127/85 with a pulse rate of 86. Normal temperature, SpO2 at 95%. Respiratory rate was 21 per minute. So within about 30 minutes, the patient was stable. The vital signs were stable, and the third and fourth antivenoms were given without any further adverse reactions. That was the patient on day 4. As you can see, the swelling has reduced quite a lot. It was just above the elbow joint. But the blood tests that were done on that day showed an increase in the white blood cell count, which you can see here. And then the neutrophil percentage was also raised. But snake bites are also known to cause an increase in white blood cell count and neutrophils, especially puffered bites. Then snake bites are also known to cause an increase in liver enzymes, especially the AST and ALT enzymes, as aspartate aminotransferase and alanine aminotransferase. This is again due to toxins and enzymes like phospholipases and proteases that can directly damage the liver cells. Again, there was also some slight increase in serum sodium, which can also be an indication of renal involvement in cytotoxic bites. On day 4 post-envenomation, the patient developed a bit of thrombocytopenia, and some puffered venoms are known to have direct thrombin-like action on fibrinogen, leading to consumption coagulopathy and platelet depletion, which can lead to bleeding. So again, you can see the chloride was also a bit elevated. A day before discharge, you can see there was a bit of liver involvement, Again, the enzymes had raised, but this is usually a temporary thing, and the liver enzymes should go back to normal. The chloride was also getting back to normal, but the hemogram, the full blood count was basically normal. On the day of discharge, which was 10 days after the bite, you can see the bitten limb is almost going back to normal, except a little bit of swelling on the hand, and the patient was discharged in good condition. So it is also very encouraging that this is a message we got from the husband, which was very encouraging to us as healthcare practitioners. And I think that is, then we also had a chance of presenting these findings at last year's IST Congress, and these were published conference proceedings which were presented at the IST Congress in Singapore last year. Now, the second case, which is a case of progressive weakness, which is the other syndrome that Professor Worrell mentioned. This was a young man, 13 years of age, male. His home is just about 6 kilometers from the snake farm, which is just about the same distance from where the hospital is. And this was a Sunday in 2013. He was bitten at about 9 in the morning on the mid shin, and there are 2 bite marks, but there was no edema. The circumstances of the bite were the boy was playing with other kids in a bushy area near the homestead, and he was bitten on the leg by this long brownish snake. From the symptoms, we later identified that this must have been a black mamba. And as you can see, it's also quite widely spread within the country. So on noticing that he had been bitten by the snake, he rushed home. They quickly found a black stone, which they put inside. The villagers gathered around a little bit for prayers for him. Then they realized he had started frothing from the mouth with a bit of labored breathing. He was rushed to the local dispensary, but they were immediately referred to the snake farm, Watamu Snake Farm, because the reason many people are referred there is that they know they will be able to get antivenom or help at least whenever they are snake bitten. So this boy arrived just after 10 in the morning at the snake farm, but he was immediately referred to my facility, and the late Sander and Ryan called and told me to prepare for a patient who had been bitten by a black mamba. So on arrival, he had typical signs of neurotoxic envenoming, semi-comatose with severe ptosis, which Professor Worrell has described. The pupils were not responding to light. He was sweating profusely. He had this sign called the broken neck syndrome, a broken neck sign. There was hypersecretion. The blood pressure was unrecordable. The pulse was very weak. He had very low oxygen saturation. So we decided to give him oxygen by ambu bag and did a bit of suction because of the secretions. From the photograph there, I'm with the late Ryan planning on what exactly to do for this patient. So we immediately gave him 2 ampules of South SAVP antivenom by direct push. Then we gave him another 2 ampules in saline drip, but we had also set an extra line for running the fluids. The patient suddenly developed severe urticaria, so we had to temporarily stop giving the antivenom, but we immediately, when the symptoms resolved, we immediately continued with the antivenom. Twice we had to do cardiopulmonary resuscitation, and the total resuscitation time was 2 hours. The patient was on oxygen for about 5.5 hours, and when the symptoms improved, we weaned him off the oxygen. because the vital signs had all returned to normal. So we admitted him for close monitoring. And 24 hours later, he could actually, amazingly, he could recall everything that happened in detail the previous day, including identifying each person. So, and in neurotoxic snake bites can actually cause paralysis and respiratory failure, but patients can remain conscious, especially in the early stages or with milder envenomation. While some cases may progress to a locked-in state or mimic brain death, many patients with neurotoxic envenomation maintain consciousness. So that is why this patient remained aware of what was happening. So again, there is this paper that there's a paper we published on this case in the Journal of Tropical Medicine and Infectious Diseases in 2018. This presentation of neurotoxicity underscores the fact that timely presentation of the patient to a health facility is key and does not require sophisticated equipment or advanced intensive care. So the third case is bleeding syndrome. Now, this was a young lady, 28 years of age. She was bitten on the 11th of August in 2013 in a place called Kakuyuni. This is about 10-15 kilometers from where we are. And she was bitten at 3 p.m. The circumstances of the bite was she was walking along a bushy path and encountered this long greenish snake crossing her path, which bit her right shin, just about 4 centimeters above the lateral malleolus. And we have always known that any snake that is green and more than a meter long is likely to be either a green mamba or a boomslang. So this patient was rushed to the homestead, which was about 500 meters from the scene. She was reported to have vomited twice. There was no history of respiratory distress or loss of consciousness. A tourniquet was applied just above the bite site. And as you've heard what Professor Worrell has said, that's why I've even indicated in red that tourniquet should not or never have been applied, but it was applied. Then the patient was taken to a local health center. The tourniquet was released and she was referred to the sub-county referral hospital in Malindi, which is about 23 kilometers from here, where she did not get any assistance. Her relatives then decided to take her to a private hospital within Malindi, where again, she was just given, like Professor said, the standard treatment that is given, hydrocortisone, Piriton, and then she was referred to our facility. She arrived at about 9 in the night. She was in good general condition, not pale, not jaundice. Temperature was 36 degrees. Blood pressure was good at 110/80. Pulse rate 72 per minute, good volume. The rest of the systemic examination was unremarkable. Locally, she had 2 visible bite marks, about 4 centimeters above the right lateral malleolus. There was a bit of swelling which had progressed to mid-shaft with increased temperature, tenderness, and warmth. We admitted the patient for observation. The initial 20-minute whole blood clotting test was normal, blood clotted. We gave her paracetamol injection because she was complaining of pain and advised her to elevate the bitten limb. In the morning, on the second day, about 6:30 in the morning, she reported bleeding from the gums after brushing her teeth. And then she also noticed that she was bleeding from the injection site. When we took another 20-minute whole blood clotting, we took another sample for the 20-minute whole blood clotting test. The blood was incoagulable, but she was still, her vitals were still stable, blood pressure of 110/70, pulse of 87. And we immediately called the Snake Farm. And fortunately, we had some boom slang antivenom, and the late Sandra Ash came with it. So we gave this patient subcutaneous adrenaline and started on SAVP boom slang specific antivenom, 10 mL into 100 mL of normal saline. That was about 18.5 hours post-envenomation. At about 10:25, antivenom infusion was completed without any reactions. And then when we checked the 20-minute whole blood clotting test at 4:30 p.m. that night, it was normal. Okay, this is day 3. We repeated the 20-minute whole blood clotting test, and it was normal. There was some reduction in swelling. So we discharged the patient, who was in good general condition. And this was the culprit snake again. Again, you can see also its distribution is quite vast in this country. So in conclusion, like I think Professor Worrell has passed through a few of this, but I would still talk about them. Every snake bite should be treated as a medical emergency unless you're sure that the bite is from a non-venomous snake. It's important to recognize and correct any immediate life-threatening conditions and refer whenever indicated. It's important to provide analgesia whenever it's necessary, assess for local and systemic toxicity, and also minimize local tissue damage, prevent or correct any systemic toxicity, e.g. hypertension or hypotension or weakness, prevent or correct any hematological toxicity, improve limb function, minimize harm from unnecessary and potentially dangerous intervention. And again, we still repeat, never be in a hurry to discharge snakebite patients. Symptoms and signs of severe systemic envenoming from the 2 hemotoxic snakes, like the boom slang we've described, can be delayed for even up to 15 hours or more. So with that, I say thank you very much for your attention, and welcome any questions.
Thank you very, very much to both Professor Worrell and Dr. Irulu for fantastic, very clear, easy to understand talks this evening. That you've had some fantastic feedback in the comments about how informative it's been. So thank you very, very much indeed for that. Dr. Williams has been beavering away in the questions and answer box, answering away on people's questions. There have been some brilliant questions. I hope that you are all monitoring the questions and answers boxes as we go. We do seem to get a lot of repetitive questions, so I suggest you do read them as the questions are answered so that we don't keep answering the same questions. But there have been some excellent questions, and it shows that people have found the session extremely interesting. There's a couple of questions here that I can ask, which we haven't yet got to. I don't know whether this is a thing. Comment on the cases of cerebral thrombosis, hearing loss, and loss of vision following snake envenoming. How common is this, and what snake types are associated with this condition, if it exists?
Well, I will reply directly to that doctor in Mogadishu. I think the most likely species would be a carpet viper in Djibouti, in Somalia. But I will reply directly to him about that. They're rare cases, but very interesting ones. So thank you for that. Could I just mention, Ali, that a couple of points came up. One was when to remove the emergency, the first aid treatment, compression treatment, when should they be removed, the tourniquet or the pressure pad? And ideally, one should not do this until the patient is in a medical facility with the possibility of resuscitation, because if you release the pressure pad and it has been effective in containing the venom, then there may be a flood of venom into the systemic circulation, and there are reported cases of rapid deterioration after release of one of these effective first aid methods. So you don't want to do that until the patient is until the patient is in an environment where they can be resuscitated and ideally given antivenom. Another question was with the treatment of antivenom reactions, and Dr. Irulu quite rightly pointed out something that I didn't mention, which is if a reaction develops, you should temporarily stop the infusion or injection of antivenom straight away. You should stop it. And you should then give the adrenaline and wait for the patient to recover. And then another very important point that Dr. Irulu made, the aim is to complete the full dose of antivenom once the patient has recovered, has been effectively treated for the antivenom reaction. And the overwhelming experience is that the patient will not have a further reaction after being given adrenaline and possibly antihistamine as well. The issue which I dodged was the exact initial dose of antivenom. I emphasize that this will vary with the type of antivenom you use, with the severity, clinical severity, and with the species of snake. And we heard quite a lot of discussion of this by Doctors Williams and Kadilkar last week. So, for example, with carpet vipers, the available antivenoms in fairly small doses, at just 1 to 3 vials, may be effective. Whereas with some of the other East African snakes, a really very large dose of antivenom may need to be given. But I didn't go into detail over that because it's a complicated subject, but it's a crucial bit of information for the treating doctor. Which dose of antivenom do I start? And I think the package insert information for the premium serums antivenoms are really quite useful in indicating the sort of initial dose that must be used. So just to reiterate, anyone who sends specific questions to me, I'd be happy to reply to them by email, including the ones from Mogadishu, which are very, very interesting. And I will be sending a PDF of my presentation for Ali to distribute to anyone who's interested. So thank you.
I think that was a fantastic evening, everybody, and we are very grateful to Professor Worrell and Dr. Irulu, and I'm extremely grateful to Dr. David Williams for answering all the questions as we've gone along. I am in a position where I can easily contact any of the speakers with questions that you have, so please don't hesitate to contact us. As you have seen, I've posted in the chat. If you go right to the top of the chat, you'll see the link to the WhatsApp group, which you can join. I have also given the link right now. In fact, I shall place it in there right now this minute. This is where I have posted the previous videos that are ready. Only 2 are ready, and I've posted the PDFs of the presentations. So thank you. Thank you. We have one more webinar to go. Professor Tim Hardcastle will be talking about wound management and post-surgical treatment of snakebite victims, and we will then follow that with a panel discussion with some of the interesting questions that we've had come up over the last 3 weeks. I appreciate all of you so much coming online and taking the time to learn this precious information, and we are forever grateful to our presenters. So thank you all. Have a great evening and good night.